Good evening, everybody, and welcome to today's webinar by CCI on lung cancer. This is a part of a series of webinar on lung cancer, and we have done six parts till now. This is the seventh part, which will be discussing on complications of lung cancer and their management. We are lucky to have a group of eminent panelists from across India for this webinar. At the outset, I like to thank CCI family for inviting us to conduct this webinar. Dr. M.S. Gopala Krishna, who is the
Hi.
Chief Interventional Pulmonologist from Ayush Hospital, Vijayawada. We have Dr. Raghukanth, who is a consultant pulmonologist at Medicover Hospital, High Tech City, Hyderabad. We have Dr. Subhajit Sen, who is a pulmonologist and intensivist in charge respiratory ICU, Fortis Hospital, Kolkata. Dr. Abhishek Prajapati, who is a senior consultant pulmonologist from Sri Krishna Hospital and Bhaikaka University, Karamsad, Gujarat. Dr. Klein Dantes, who is a senior thoracic surgeon from AIMS, Bathinda. And last not the least, Dr. Karl Mehta, who is a consultant pulmonologist at Tralife Hospital, Bengaluru. So we have a group of pulmonologists and thoracic surgeons from across India who will be discussing about how to diagnose and manage the complications of lung cancer, and they'll share the knowledge and wisdom with all of us. To begin with, I'll ask Dr. Gopala Krishna to have a presentation on management of lung cancer, complications of lung cancer. He will be presenting an overview of it. I'll ask the audiovisual team to start the presentation of Dr. Gopala Krishna on complications of lung cancer and overview.
Good evening, everyone. At the outset, I would like to thank the CCI organizers for giving me this opportunity. It's always an honor and privilege to be among the esteemed CCI faculty. And to introduce myself, I am Dr. M.S. Gopala Krishna, Chief Intervention Pulmonologist working at Ayush Hospital, Vijayawada. So as we know, the lung cancer remains the leading cause of cancer-related mortality worldwide. But beyond the primary tumor itself, it is often the complications that define the patient's clinical course, quality of life, and sometimes even survival. In my today's session, I will be discussing some of the most important complications we are encounter in our daily practice due to lung cancer. These are not just medical challenges, but emergencies that require timely recognition and effective intervention. Through this presentation, I will highlight these clinical manifestations, the role of diagnostic tools, and most importantly, the interventional strategies that can help to restore the airway patency, to control the bleed, manage the pleural effusion, and to relieve the vascular obstruction. So my focus will be on practical case-based approach, emphasizing how the interventional pulmonology can make a real difference in improving both the outcomes and quality of life. So coming to the lung cancer complications, I can classify the complications based on the anatomical location. So it can be airway related, or it can be vascular, or lung parenchymal per se, pleural complications due to lung cancer, and systemic complications in the form of musculoskeletal and metabolic, and complications related to the treatment part. Why the complications, lung cancer complications are important? If you look at the burden and prevalence of the lung cancer related complications, the central airway obstruction accounts nearly 20 to 30% of all lung cancers, and hemoptysis, approximately 20% of lung cancers may experience hemoptysis in their due course, and pleural effusions, approximately 50 to 55% of lung cancers may have a pleural involvement. Because of the common sharing etiology of cardiovascular diseases and lung cancer, the CVD risk is approximately 23 to 36% of all lung cancers, and paraneoplastic syndrome's prevalence ranges from 5 to 15%. And the complications will depend upon the staging of lung cancer and the histological variant and anatomical location of the tumor. So these are the common complications we'll encounter during our practice, starting from central airway obstruction, hemoptysis, malignant pleural effusion, tracheoesophageal fistulas, venous thromboembolism, superior vena cava obstruction, and cardiovascular related like coronary artery disease and pericardial effusions, pain due to metastasis, breathlessness, and fluid and electrolyte imbalance mainly due to as a part of paraneoplastic syndrome. In view of time constraint, I am going to concentrate my talk on central airway obstruction, management of hemoptysis, malignant pleural effusion, and few important points regarding superior vena cava obstruction. Coming to the malignant central airway obstruction, it refers to the malignant mechanical obstructive process that impedes the airflow within the central airways, starting from larynx to the main bronchi. It is difficult to differentiate the specific incidence and prevalence of mechanical central airway obstruction, but according to the previous studies, approximately 20 to 30% of all lung cancer patients may experience central airway obstruction at any point of time, and as many as 40% of lung cancer deaths are related to loco-regional disease. And a more recent cohort review found that 30% of patients with newly diagnosed lung cancers have central airway obstruction at presentation, and an additional 5% develop this complication within 4 years of the diagnosis. Coming to the etiology, the central airway obstruction can be due to primary endoluminal carcinoma arising from the either bronchogenic spread or adenoid cystic carcinoma, mucoepidermoid, and carcinoid, and metastatic carcinomas mainly from the lung parenchyma, followed by renal, breast, thyroid, colon, sarcoma, and melanoma. Laryngeal, esophageal, and thymus and thyroid malignance directly can invade the trachea and major airways and can cause central airway obstruction. Sometimes a large mediastinal lymph nodes can cause central airway obstruction by extrinsic compression or direct invasion into the airway. So we can classify the central airway obstruction depends upon the invasion of the airway. It can be either endoluminal obstruction, or it can be extrinsic compression, or it can be a mixed obstruction. Endoluminal obstruction mainly confined within the or intrinsic obstruction confined to the lumen will cause mainly airflow obstruction, whereas extrinsic compression is mainly due to the adjacent tumor causing compression effect over the trachea. And sometimes an invasive tumor or aggressive tumors can invade the bronchi, and it will cause both the extrinsic as well as infiltrative lesion into the major airways. Coming to the pathogenesis, the mainly pathogenic process can result in a fixed airway obstruction. Patients may have dyspnea at rest, especially the lumen was narrowed to either 5 mm or more than 75% of the diameter of the airway lumen. And patients may develop dyspnea on exertion if the tracheal lumen is narrowed to 8 mm or at least 50% of diameter of the trachea is involved. Coming to the clinical manifestations of central airway obstruction, cough, blood-stained expectoration, breathlessness, hemoptysis, chest pain, stridor, hoarseness of voice, and dysphagia. And most of the times, malignant central airway obstruction is misdiagnosed as exacerbation of COPD or asthma, or sometimes it is diagnosed as bronchitis and pneumonia. So when we have to suspect central airway obstruction, there will be definitely some clinical clues. If the patient's breathlessness is constant and it is not responding to your regular bronchodilators treatment, and clinical examination has proved that the patient is having a unilateral monophonic wheeze, especially if the lesion comes below the level of carina, and symptoms and radiological infiltrates that do not resolve within 4 to 6 weeks of your regular antibiotic therapy, then we have to suspect central airway obstruction. Then coming to the approach. So diagnostic approach needs imaging. Spirometry sometimes help in picking the diagnosis, and bronchoscopy is the diagnostic evaluation of central airway obstruction. And therapeutic central airway obstruction management needs like airway stabilization, palliative debulking, and airway stents plays an important role in management of central airway obstruction. Imaging and bronchoscopy are very crucial in management of central airway obstruction, not only the diagnosis and also to assess the vascularity and nature of the tumor and to assess the distal patency of the airway. So you need to have a proper imaging and bronchoscopy. So we can plan the treatment according to the level of obstruction and level of infiltration. Sometimes spirometry can give a clue, especially depends upon the site of involvement. If it is an extrathoracic, you may have a patient may have a inspiratory loop flattening, and if it is intrathoracic, there will be a expiratory loop flattening, and if it is a fixed airway obstruction, there will be flat box pattern. Then coming to the treatment goals of central airway obstruction, the aim is palliative debulking, then airway stabilization, especially if patient is having extrinsic compression, and airway restoration in case of airway compression as well as infiltration. So there we need to do a debulking procedure and sometimes need a stent also. And it is again a multidisciplinary team approach. You need to have a good bronchoscopic theater and all the facilities for airway stenting and tumor debulking procedures. Then coming to the bronchoscopy. So which scope is preferable, whether flexible or rigid? So flexible is having its own advantages and disadvantages, but rigid is mandatory for management of central airway obstruction. Most of the times, flexible bronchoscopy is useful for diagnose the tumor, to assess the severity and to assess the site of obstruction, whereas rigid bronchoscopy having its special role, especially because of its large rigid bronchoscopic lumen. So we can able to debulk the tumor in the same sitting, and we can able to maintain the airway patency during the procedure. And commonly we'll use both the thermal and as well as non-thermal modalities for management of central airway obstruction. Coming to the thermal ablation techniques, like we can use the laser, electrocautery, and APC. And for non-thermal interventions, we can use either photoalarmic therapy or simple dilatation with your rigid bronchoscope, debridement with a micro debrider, and stent is mainly to restore the patency of the airway. And you need to have all this equipment for management of central airway obstruction. And this is the algorithm to follow the central airway obstruction. If the central airway obstruction is an emergent, so if patient is suitable for surgery, then better to take the patient for surgery. And if it is not, he is not fit for surgery, then we have to plan either endoluminal dilatation in the form of coring, or ablative techniques by either using laser, electrocautery, or organ plasma. And stent is to maintain the patency of the airway and to prevent recurrence of the tumor. Whereas curative resection is not is possible with so patient can be mobilized for surgery. Then coming to the malignant pleural effusions. The malignant pleural effusion is the second leading cause of all pleural effusions, which accounts for 22% of all pleural effusions and 42% of all exudative pleural effusions. The diagnosis is by demonstrating the exfoliative malignant cells in the pleural fluid or in the pleural tissue obtained by closed pleural biopsy or thoracoscopy. Paramalignant effusions defined as the effusion is related to the malignancy but absence of malignant cells. The lung cancer, at the time of diagnosis, 15% of all the patients will have pleural effusions, and 40% of all the patients, lung cancer patients, may develop pleural effusion during the due course, and 50% of patients with disseminated lung cancer will develop pleural effusions, and pleural effusions are more common with adenocarcinoma and rare with small cell carcinoma. And coming to the causes of malignant pleural effusion, commonly it is mainly due to the pleural metastasis, which increases the permeability of pleural lymphatic obstruction, or due to mediastinal lymph node involvement with due to decreased pleural lymphatic drainage, or maybe due to thoracic obstruction, which can cause chylothorax, or due to bronchial obstruction or pericardial involvement. The indirect causes of malignant pleural effusion is mainly due to either volume overload or post-obstructive pneumonitis, sometimes pulmonary embolism, and post-radiation therapy. There are n number of causes that can produce paramalignant effusion, starting from local effects due to lymphatic obstruction, bronchial obstruction, and trapped lung, sometimes chylothorax, and pulmonary embolisms. All these things can cause paramalignant effusions. Then coming to the clinical manifestations of malignant pleural effusion, most common manifestation is breathlessness followed by cough and chest pain. And breathlessness is very common. It's more than 50% of patients may have breathlessness. And malignant pleural effusion is usually patients may have dull chest pain, but benign pleural effusions will have pleuritic kind of chest pain. Then coming to the approach, we need to have a chest X-ray, CECT, or PET-CT for making the diagnosis of pleural effusion, to assess the lesion and to assess the metastatic spread of the tumor. Ultrasound is very, very useful for management of pleural effusion, especially to locate the effusion and as well as to quantify the effusion and to look for any loculations and for placement of chest drains and indwelling pleural catheters. Bronchoscopy and EBUS for establishment of diagnosis, and thoracoscopy is the diagnostic modality for diagnosis of malignant pleural effusion. So we can take a pleural biopsy and at the same time we can do a therapeutic procedure by doing a therapeutic drainage as well as pleurodesis. Coming to the characteristics of malignant pleural effusion, malignant pleural effusions are usually serous or serosanguineous or hemorrhagic, typically exudates, and lymphocyte predominant. If it is, and usually it is more than 50% of effusions are lymphocyte predominant, and 1/3 of pleural effusions pH will be low, and usually the malignant pleural effusion will have high LDH levels. And cytology is more sensitive than any percutaneous pleural biopsy. The yield of fluid cytology is 40 to 80%, and mostly adenocarcinoma accounts positive yield for adenocarcinoma is high, followed by squamous cell carcinoma. For lymphoma, the cytology sensitivity is 25% in Hodgkin's and 50 to 60% in non-Hodgkin's. Closed pleural biopsy, the positive yield is 40 to 75% and less sensitive in especially in comparison with fluid cytology. And CT-guided pleural biopsy, either from the pleural nodule or thickened pleura, can increase the yield of diagnosis. Thoracoscopy is the diagnostic modality of malignant pleural effusion. The diagnostic yield is more than 90%, and for a mesothelioma, it is 100%. And the advantage of thoracoscopy, it is a daycare procedure, and both diagnostic and therapeutic can be done in the single sitting, and most of the times can be done the procedure under local anesthesia or conscious sedation. General anesthesia usually needed for advanced thoracoscopic procedures, and a big advantage of thoracoscopy is we can do the pleurodesis in the same sitting. How to manage the pleural effusion? A repeated thoracentesis usually will do at the first time of presentation, but the repeated thoracentesis can cause pleural infection and development of flocculations that can lead to trapped lung. Chest tube drainage and talc pleurodesis, especially for massive pleural effusions, can give instant relief, but long-term chest tube drainage can cause pleural contamination that can lead to empyema, and patients may have pain and other complications. And medical and surgical thoracoscopy and talc boundaries is the treatment, especially for recurrent malignant pleural effusions. Pleurectomy and decortication for mesothelioma, and indwelling pleural catheters having its main advantage, especially patient is having recurrent pleural effusion and the lung is trapped due to septations. So indwelling pleural catheter having its own advantage. So it can be done as a daycare procedure, easy to insert. The compliance rate with indwelling pleural catheter is very good. And the big advantage, it is self-manageable. The patient can manage by himself at home. So usually it is made up of silicone material. So it will having its own safety features like a one-way valve and a polyester cuff in between in the center of the catheter, so that which can induce the fibrosis and inflammation in the chest wall. So there will be a chance of pleural infection with indwelling pleural catheters, and the catheters can be tunneled subcutaneously. That can reduce the chance of infection risk into the pleural cavity. And the main advantage is it can be self-manageable. So with the proper training, the patient can drain the pleural effusion at home by provided vacuum containers. The medical thoracoscopy useful for the diagnosis. Most of the times it will be done by pulmonologist, especially the medical thoracoscopy in an endoscopy room or a surgical theater, and can be done under local anesthesia. The indications are very clear for diagnosis and as well as for therapeutic purpose. So we can take the pleural biopsy, we can do the adhesion lysis, and we can drain the loculated effusions with thoracoscope. And at the same sitting, we can do the pleurodesis. Apart from diagnosing the malignancy, so we can able to take the big chunk of biopsy with the thoracoscope. And now cryo is emerging its role in pleural biopsy. So the advantage of cryo pleural biopsy is preservation of the tissue. There won't be any artifacts. So especially useful for diagnosis of mesotheliomas and as well as adenocarcinoma related metastasis. The take-home points here are the pleural fluid cytology, it is more than 40%. And if you combine with the pleural biopsy, immunohistochemistry, the yield will increase. And repeated thoracentesis can cause infections, adhesions, and loculations and pleural tapping. Chest drain can give rapid symptomatic relief, but pain and pleural infection risk can be increased. Thoracoscopy is the diagnostic modality of management of the malignant pleural effusion. The pleurodesis not only useful for permanent cure, but may not be useful in trapped lung and patient and the lung is collapsed. Inwelding pleural catheters will give a symptomatic relief and safe, and it can be self-manageable. Then coming to the another important complication, hemoptysis. Approximately 20% of all lung cancer patients may experience hemoptysis during the course of treatment. Sometimes it is a serious complication, may become life-threatening, especially when it is severe, or it may be an initial manifestation of malignancy. Coming to the pathogenesis of hemoptysis, it can be due to tumor-related angiogenesis or tumor necrosis, or maybe direct invasion of the tumor into the blood vessels, or tumor surface shedding. Sometimes cough-related irritation can cause hemoptysis and may be due to secondary infections. The common source of bleeding, especially in lung malignancy, are mainly due to from the bronchial arteries, especially 90% of cases, the bleeding from the bronchial arteries, and 10% in pulmonary arteries. And severity of hemoptysis, even though it is minor, any amount of blood in the sputum, even it is a rusty colored, needs to be addressed completely. So you need to have a diagnostic bronchoscopy to evaluate the cause of hemoptysis in patients with lung cancer. And if it is severe, that means if it is patient is coughing more than 2 to 3 teaspoons or exceeding more than 600 milliliters, it needs, it means it's a life-threatening hemoptysis and require immediate emergency care. Here, the goals of management of hemoptysis is, first of all, to identify the site and side of bleeding, then positioning the patient, and to establish a patent airway, and to ensure adequate gas exchange, and ensure adequate cardiovascular function, and finally, to control the bleed. The debates in this area are either we should go with CT first or bronchoscopy, whether all hemoptysis needs a bronchoscopy. If you want to do a bronchoscopy, either it is a rigid bronchoscopy or a flexible bronchoscopy, or who have to manage, either an intervention pulmonologist or an intervention radiologist. But we have to forget about all these debate things. We need to have a proper imaging to establish the diagnosis, to localize the lesion, and as well as to assess the severity and extent of the tumor. CT is the best tool. It can give the sensitivity of localization is 70 to 88.5% with the good CT image. But bronchoscopy is especially useful if patient is having bilateral lesions, and arteriography sometimes is useful, especially if patient is having presented with massive bleed. So it will be helpful to isolate to identify the bleeding site, and as well as to thrombolize the bleeding if patient is bleeding heavily. Then the important goal is to protect the normal lung by keeping the patient in lateral decubitus position. So that way we can prevent contamination of the normal lung. Then secure the airway in the means of endotracheal tube or a combi tube. The best is the rigid bronchoscope. So we can remove the clots, and at the same time we can secure the airway, and we can do a therapeutic intervention. So coming to the bronchoscopic measures, so what bronchoscopic measures we commonly use for management of hemoptysis are endobronchial occlusion, like lung isolation, and for unilateral lung ventilation, and placement of double lumen endotracheal tubes and bronchial blockers, and placement, and sometimes we can do a balloon tamponade, especially if the bleeding is from a segment. And we can inject some vasoconstrictive agents or cold saline to control the bleed. And to deliver the hot therapies, you need to have a bronchoscopy. The rigid bronchoscopy is the ideal tool because of its large lumen, so that can facilitate the suction and better clearance and improved visualization. So balloon tamponade is sometimes needed, especially if patient is having massive bleed. So we have to protect the normal lung by flooding blood from the diseased lung. So need to have a endotracheal tube, or you can double lumen endotracheal tube, or we can use a Fogarty balloon if especially the bleeding is from a segment. Or you can use a silicone spigot temporarily block the bleeding segment. Then coming to the ablative techniques. So you can use a Nd:YAG laser or APC or electrocautery. All these ablative therapies will have the same mechanism. So you can control the bleed quickly by cauterizing the bleeding tumor. And embolization is sometimes needed, especially patient is bleeding heavily. And most of the times we need to have blocked the bronchial arteries are the main source of bleeding. So nearly 57 to 100% of patients may develop symptomatic improvement. Sometimes patient may develop recurrent bleed following the bronchial artery embolization. So the take-home points here, it is hemoptysis is always a life-threatening. So mild hemoptysis should not be ignored. Always needs to prompt action, and the goal is to secure the airway. And it is a multidisciplinary team approach, and need to have all the equipments to manage the bleed and find the cause and treat the cause. Then coming to the cardiovascular complications of lung cancer, mainly due to the increased thrombus risk and mechanical obstruction by the tumor growth and lymph node mass, or by the direct tumor invasion into the vessels. All these things can cause the vascular complications. And because of the common sharing etiology, the incidence of cardiovascular diseases, heart failure, and arrhythmias risk will be very high in especially patients with lung cancer. Superior vena cava obstruction, mainly due to the compression or invasion of the SVC by tumor or nodes. Mostly patients may have facial swelling, venous distension, dyspnea, or headache. The diagnosis mainly by either CT angiogram or CT venography. The management includes steroids, diuretics, stenting, and radiotherapy and chemotherapy. And sometimes we can manage the SVC with stenting. So here you can see there is the significant SVC obstruction we are managing with the vascular stent. The flow was completely restored after vascular stent. Then coming to the paraneoplastic syndromes, it can be classified into endocrine, neurological, hematological, dermatological, and most important endocrine paraneoplastic manifestations are syndrome of inappropriate antidiuretic hormone secretion, Cushing's syndrome, hypercalcemia, and neurological complications include Eaton-Lambert syndrome and neuropathies, and hematological complications like hypercoagulability, anemia, and leukocytosis, and dermatological complications like acanthosis nigricans and dermatomyositis. And sometimes the paraneoplastic syndromes may precede the cancer diagnosis. So we have to address the paraneoplastic syndromes very precisely. So sometimes that can be helpful for diagnose even the primary tumor. So coming with this, I am going to conclude my talk that lung cancer complications can contribute significantly to the morbidity and mortality. Timely recognition and multidisciplinary management are very crucial. Palliative interventions can improve the quality of life. Thank you.
Thank you, Dr. Gopala Krishna, for excellent presentation and excellent overview of complications of lung cancer. Now we move on to the next part of this webinar, where we'll having 3 cases. These are all real-world cases where we will be discussing about how these cases have been managed by our eminent panelists. The first case will be presented by Dr. Gopala Krishna. is on central airways obstruction. The second case will be by Dr. Raghukanth A, which will be on malignant pleural effusion. And the third case will be on hemoptysis by Dr. Karl Mehta. Each case will be followed by a panel discussion of about 15 to 20 minutes. So I request Dr. Raghukanth, I request Dr. Gopala Krishna to please share the screen and share the case with us.
Yeah, sure, sir. Yeah, is it okay now? Can you able to see my slides?
Yeah.
Yeah. So now I'm going to present a case of a central airway obstruction. This is a 50-year-old female known to have adenocarcinoma left lung, which was diagnosed in the year 2014. And she took chemotherapy and radiotherapy for that. And now she presented with the complaints of progressive breathlessness. At the time of presentation, she is having stridor and she is in severe respiratory distress. And this is the CT film of that patient at the time of admission. You can see here, there is a complete collapse of the left lung and the entire mediastinum is shifted to the left. And you can see there is a significant narrowing of the lower end of the trachea. And you can see almost lower end of distal trachea is pinpointed. So this is the bronchoscopic image of that patient. So now I am playing the bronchoscopic video. This patient is having a very aggressive tumor with high vascularity involving the lower tracheal rings and extending up to the carina and right main bronchus. But unfortunately, the left main bronchus is not visualized, maybe due to chronic obstruction and stenosis. That is the reason for complete collapse of the left lung. This is how the lesion looking. So you can see the tumor arising from the posterior membranous portion of the lower trachea, and you can also see the vascularity of the tumor here. It's highly vascular and just bleeding on touch. This is the case. So patient is having respiratory distress and stridor was there and she was hypoxic at the time of presentation. So we decided to do a debulking procedure. Plus or minus stent, we kept the option because we are not sure how far the tumor was extended, because I cannot able to see the entire right bronchus, and I am not sure what stent I am going to use because I cannot see the entire tracheobronchial tree. So first we started doing the debulking procedure. So we intubated the case with the rigid bronchoscope. So later we started debulking the tumor by using the electrocautery snare, where you can see the tumor is because of its highly vascularity. So it's bleeding on touch. So what we did here, we used the first in the electrocautery snare, so we can able to ensnare the tumor with the snare. Then we fired the snare. So with that, we can able to cut the tumor. So here you can see the resected tumor. So then the big chunk of the tumor we removed with the same electrocautery snare. You can see how we are removing the chunk of the tumor. Luckily, the posterior wall was patent. There is no any much damage. So then later, hemostasis was achieved with APC and electrocautery. And then finally, we can able to reach the carina. But unfortunately, the right bronchus is origin of the right bronchus is also involved, and carina is also involved. But left main bronchus was not visualized due to chronic stenosis. So then, because the wall is not intact, so we want to place a stent. So the problem is here, how to place the stent, because the carina is involved, the right bronchus is involved, and the lower trachea is involved. So what we did here, we took the straight stent because left main bronchus was completely closed, so we cannot place the Y stent here. So what we did, we have taken the right straight tracheal stent, and we placed the distal end of the straight stent directly into the right main bronchus, and then the proximal end in the trachea. So the stent was covered completely the malignant portion, and we can able to open the right bronchus. And this is the post procedure film. So the right lung was patency was maintained, the bronchus was opened completely, and the left lung, because that there's a complete stenosis, we cannot able to do anything for the left lung. Later, the patient was discharged for chemotherapy. This is about the case. So basically, this patient is having a single lung with a very advanced disease, and it's a recurrence, and the tumor is highly vascular, and it's involving the lower trachea, carina, as well as the right main bronchus. So we did graded tumor debulking procedure by using electrocautery snare. Later, airway was stabilized with a straight stent here.
Thank you, Dr. Gopal. Now we start the panel discussion of this case. My first question is to Dr. Karl Mehta. Dr. Mehta, how do you clinically suspect a case of central airways obstruction, and how do you confirm it? What's your way of doing it?
So thank you, sir, for the questions, and thank you, CCI. So the main thing is that you have to go clinically. So obviously, when you have a patient with malignancy, you're going to get symptoms of cough, breathlessness, weight loss, loss of appetite. But what the key things that you need to know, which should give you a high index of suspicion, is that you will hear that they'll have stridor, one of the cardinal signs. So stridor is something that can happen, and as well as their wheeze. Their wheeze is a little atypical. It isn't that musical, audible sound that you'd hear. It's more like a crowing sound, as if a crow is cawing. So that's something that you have need to, that tells you that you should have a high index of suspicion to suspect something central airway. Sometimes you will also get, if the neurovascular system or vocal cords are involved, you can get hoarseness or voice change in voice, or a loss of phonation as well. So those are some of the things that you should suspect, so that you should keep in mind when you're evaluating them clinically based on history and examination. And in terms of confirmation, the main two aspects will be, one is you're going to ask for a CT scan of the chest, and obviously you're going to ask for contrast enhanced so that you can delineate the tumor versus the vascularity and have a good understanding of the vascularity. Plus, it gives you an understanding of the surrounding structures involved as well. Certain centers, you can do a 3D reconstruction. It's more available now, given the advancements in software. So that also helps. And in very few centers, you can even do a dynamic study. So you can see breath to breath, the change and the dynamism of the tumor. So that's something else that can be done to confirm. And then that's your radiological, so you get the extent and volume. And then you want to do a bronchoscopy, like Dr. Gopal Krishna has clearly elicited in his presentation. You do a bronchoscopy, understand the size, the level of obstruction, go beyond the tumor if you can. Always negotiate your flexible scope to go beyond the tumor, see if there's any infection pus, see whether there's patency of the airways below. If you can, if it's not, record that you haven't, and that's another thing that can be done.
Thank you. That was really interesting, and this will really help the audience to understand how we can clinically suspect a patient with central airways obstruction. Now, my next question is to Dr. Raghukanth. How do you approach a patient with acute respiratory distress due to clinically suspected central airways obstruction? How do you do that? We want to learn from you.
Yes, sir. Thank you, sir. It's very challenging when you're dealing with a central airway obstruction, especially in acute condition. So always, first initial assessment should be there, whether it's a patient complaint only breathlessness, which could be out of proportionate or sometimes at rest. So always the initial sign which we need to be alert is the stridor, because airway normal lumen is 16 to 20 mm of normal diameter, but stridor will occur only when you reach a 50% narrowing. So when already a 50% compromised lumen, and we need to catch that stridor or wheeze. The patient may send only the complaint that sir, I'm getting a sound, but majority of them they will they may give an history as a wheeze. So we need to catch that whether it is wheeze or stridor. That is most important sign when you're dealing with the central airway obstruction. Then we need to assess whether patient is acute stage, whether patient is able to talk properly, like the severity of breathlessness, whether it's a grade 4, is it a completing sentence, and whether using accessories muscles. So these are all impending towards the airway collapse or a critical narrowing state. That will give you a clue idea whether what is the state of the patient. Then ultimately we need to see the breathing, what rate of whether tachypnea is there, hypoxia is there, and tachycardia. All these we need to assess, and also we need to see the level of the consciousness, like the altered sensorium. All this we need to have, and a good thorough clinical examination. Initial clue will also give you sometimes where we are dealing in a stridor with acute and known malignancy, or when you see engorged veins or the chest or a puffiness, always we will give are we dealing with SVC syndrome or a mediastinal this mediastinal mass or compressing the airway or the major airways. So these initial assessment will give you an initial clue, but always you need to see a red flag signs, whether in spite of adequate oxygen, whether the patient is getting at least above 90 of saturation, whether patient having any cyanosis, level of consciousness. All we need to see any stridor, inspiratory or expiratory. All this we need to see in a quick manner to get the initial assessment. Later we need to stabilize patient, whether to protect the airway, good oxygenation, nebulized medication if you're suspecting adrenaline nebulization, when you're suspecting laryngeal edema, IV access and IV steroid. All this will give you immediate stabilization of the patient to know the in case of suspected airway, central airway obstruction. Later, we need to parallelly go for initial diagnostic workup, where the best way modality when patient is unstable at the bedside. Initial stabilization is also the main focusing on the lying the position. The position is also important, and don't give too much of sedation. Always upright or recumbent position and good oxygenation. And then bedside basic ABG and chest X-ray will give you a clue what is the etiology, whether it's a central airway with a mediastinal tracheal column. We can assess with a simple X-ray, and ABG, which give you the level of blood gases, that will give you whether the patient is require immediate intubation or not. All these factors will play a role. If the patient is stabilized with the initial assessment, initial medication, if you're giving time, airway is protected, then we can go for a CT neck and chest with the tracheal protocol, so that we can know the exact etiology of the airway obstruction, whether it's obstruction at the glottis level or the tracheal or the main stem. Then we can plan the modality of treatment to know the what is the definitive treatment plan. So if we won't give the time, then it's better to secure the airway, and check bronchoscopy will give you initial assessment, and then we can follow up to the definitive treatment, and the patient can shift it to surgical unit, operation theater, and all we can plan the other way. So once it's stabilized, initial assessment and the other blood workup, all this we can do, and the basic cardiac echographic can be done, so that we can helpful for the assessing the definitive modality. The definitive modality of management is always in the critical airways, as we seen in the previous speaker, that Gopala Krishna clearly given the rigid bronchoscopy will play a role, especially when emergency coring of the tumor, that is the play a role initial step which will secure the airway. Then with use of the bronchoscopy as a conduit, the additional to deal with the cautery or controlling the bleeding or tumor by snaring, tumor excision snaring and cryo. Using other modalities, we can increase the patency. And based on the other further this thing, then we can plan the whether this patient really requires stenting or not, on the depending upon the cause. But this not only other modalities can be useful in case of a patient is under a large lymphoma. A radiation is also helpful. If you have a good tertiary hospital with a good critical care background, ECMO can be useful when you are dealing with a complex airway obstruction. So it's a and the other option is like a tracheostomy when you're dealing with glottic obstruction, or sometimes a tracheal reconstruction with patient is initially stabilized and we know the benign cause of this. So all this multidisciplinary approach.
Yes, agreed.
Yes.
I think you have really given a brief idea about. I think it's first is stabilize the patient, ABC, and then this should be followed by definitive treatment in the form of bronchoscopy, debulking, and if required, if it is a central airway obstruction due to a malignant tumor, debulking followed by SOS airway stenting. So that's the usual step. I think in the continuum of the same discussion which we are going on, I would like to ask Dr. Gopala Krishna, what is the optimum preparation needed? I think a lot of youngsters must be having this question, that what is the optimum preparation needed in terms of tools, team, and training while managing a case of malignant central airways obstruction? We have to be specific about it. We are not discussing about benign in this. So what is your how you will like to tell us about which is the optimum preparation required in terms of tools, team, and training for the youngsters who want to start treating central airways obstruction? Dr. Gopal.
Yeah, that's an excellent question, Dr. Sushil. To be frank, managing a central airway obstruction is not a one-man show. You need to have a properly trained team. That team should consist of a trained intervention pulmonologist. You should be very skilled enough to do a rigid bronchoscopy and as well as a flexible bronchoscopy. And you need to have a confident, experienced anesthesiologist who should be very comfortable with you, and they should have a proper experience in airway management, jet ventilation, and they're able to do the difficult airway management. And all your like technicians, staff, or maybe nurses, they should have enough training in bronchoscopy and stent deployment equipment, and they should be aware of all your bronchoscopic tools and equipment. So this is the team requirements for any case of management of central airway obstruction. Then coming to the tools and equipment, it is better to be done in an operation theater. So usually the operation theater should be equipped with all the anesthesia workstations and other ventilating equipment, or it can be done in a completely equipped endoscopy suite, which should contain all your anesthesia workstations, jet facilities for jet ventilation and all. And the theater should have all the tools like debulking and ablation tools. If you take like electrocautery, which is a cheaper modality almost available in every hospital, so we can utilize the electrocautery. But before using the electrocautery, make sure that the cautery is working and check all the pins and everything, and make sure that all your train like maybe assistants should be aware of that connections and all. And if APC is there, the APC is having its own advantage, so we can use the APC for quick and superficial coagulation of the bleeding tumor. And the depth of penetration of APC is very less, so it is very, very useful if patient is bleeding. And laser, it's a costly affair. Many hospitals may not afford. If it is there, it's an add-on advantage because laser can produce less fumes and vapor. So the comfortness will be definitely good when compared with laser. And other non-thermal ablation tools like cryo, especially for tumor extraction, and balloons, especially to control the bleed. So you have to keep all different sizes of Fogarty's, or sometimes you can use a ERCP balloons to control the bleed. And coming to the stent, so it's always keep at least 2 to 3 sizes of stents readily available in your endoscopy room or in the operation theater, because we don't know like what size of stent we may need during the procedure. So it's always keep at least 2 to 3 sizes, both the covered nitinol stent as well as the silicone stents. For a simple extensive compression, a silicone stent. But a invasive lesion and endobronchial luminal obstruction, you need to have a covered nitinol. So try to keep at least 3 to 4 different sizes of stents. Then every procedure of central airway obstruction needs to be a pre-procedural imaging. So that can be helpful, especially to assess the airway and to assess the distal airway, like obstruction airway below the level of obstruction, and to study the patency of the lung parenchyma. All these things can be studied with your clear-cut CT imaging. And it's better to do all the coagulation profile, blood grouping, and other blood investigations and cardiac evaluation if patient is not in emergency crisis. And if it is not your high volume center, that means because the incidence of CAO is less, so hardly sometimes some hospitals may see 1 or 2 cases in an year. So it's always the entire team should go or should take a rehearsal training based on either simulation based or maybe case based scenarios needs to be followed, that can improve the competence of the team and that can build up the confidence, and the team should be prepared when the case arrives. I think these are the mandatory preparations for the management of CAO.
I think that's important because if the volume is very less, then you can't keep a lot of strengths in your department. So you may have to be prepared for debulking, and then maybe you may do the stenting at a second step, because sometimes it's not possible to have all the strengths in your department, especially when you are a beginning, you're starting a interventional pulmonology unit where the volume is very less. So maybe later, once the volume is more, you may have multiple stents, but at least you should be ready with debulking modalities, especially flexible and rigid bronchoscope both. You should be trained in both flexible and rigid bronchoscope, and you should be having all the necessary tools before you start airway procedures, central airway procedures. That's very, very important. And I think anesthetist has to be also very well trained. You should have a very good discussion with the anesthetist and pre-plan the procedure in every patient. That's an important message. Thank you, Dr. Gopala Krishna. Now I move on to the next question to our panelist, Dr. Subhajit Sen. Dr. Subhajit, is it a rigid bronchoscope always needed when we are managing a case of central airways obstruction? This is again an important question for the beginners. And what is the optimum rigid bronchoscopy equipments needed for managing these cases?
Thank you, sir. So, if we are talking about malignant central airway obstruction, then I like to say that we should have a rigid bronchoscope setup in our armamentarium when we are approaching the patient. If we are talking about benign, then comes the role of only flexible bronchoscope. But in case of malignant central airway obstruction, I think having a rigid bronchoscope gives some added advantage. Like we have a better or a wider area of a working area, better suctioning. These tumors tend to bleed a lot sometimes, so we can have better control of the bleeding, and through that rigid bronchoscope conduit we can always pass the flexible bronchoscope and use our multimodality techniques through which we can effectively debulk the tumor. We can maintain the patency of the airway. Even with the rigid bronchoscope we can put silicone stents also. So all the procedures can be done through rigid bronchoscope more comfortably if we are dealing with a malignant obstruction. Some cases where there are small lesions which are less than 50% occluding the lumen, or you are not having a proper setup for rigid bronchoscope, or if sometimes your anesthetist is not confident in putting the patient with rigid bronchoscope, then we can try with flexible bronchoscopy. But in my advice, if there is a tumor and it is occluding the airway and it's a malignant lesion we are suspecting, having a rigid bronchoscope always gives us added advantage in managing those tumors. And regarding the second question, sir, what are the instruments we should have? I think the more is the better. More instrument I have in my armamentarium, my confidence will be more. At least we should have the rigid bronchoscope of different barrel size, a tracheoscope and bronchoscope both, and a good suctioning device, connector device with both jet ventilation facility or conventional ventilation facility, different types of forceps, including your hot biopsy forceps, the electrosurgical snares, the cauteries. These are the hot instruments, the APCs, and among cold instrument, our cryobiopsy forceps. These are always essential for managing a airway. And also, if we are planning for a stent, so different type of stents, which sir just told before, there we should have different size of stent available in our armamentarium when we are planning for this procedures. And always it is better to do it in a OT, preferably if you have a C-arm. It is not preferably, it is mandatory to have a C-arm guidance when we are placing a stent, or we are doing a procedure, or having a C-arm or a fluoroscopy gives us added benefit in managing the airway better.
Yeah, thank you. I think it's difficult to have the whole spectrum of equipments, but at least rigid bronchoscopes, 5.5, 6.5, and 7.5 size. If you're dealing only with adult cases, that's usually these barrels must be there with you. And for pediatric, you require thinner ones like 4.5 and 3. I think that's the usual one which is needed to start with, and then you can gradually have more equipments. What's your opinion, Dr. Gopala Krishna? What do you keep in your setup?
So regarding stents, I think.
No, I'm talking about sizes of the rigid scopes, because you can't have every possible size of the rigid scopes.
Yeah. Actually, at least we should have a one tracheoscope that can able to allow the bronchial sheaths into the. So we should have a bigger size tracheoscope so that we can use that as a conduit. Later
You
we
are
can.
saying 7.5 or 8.5, something like that. 8.5.
Yes, sir.
Yeah.
And actually then followed by the smaller size of bronchial, like 8, 9, 10 rigid bronchial sheaths for the rest of the procedure.
Okay. Now again, different companies have different format, but then usual which we use is like 5.5, 6.5, 7.5, and 8.5. That's the usual one in my spectrum, which we keep for adults. And in pediatric, we have to go for smaller sizes. So that's, you have to have at least some basic equipment to start with, and then gradually you can add on. And you have to have all possible forceps, like stent holding forceps if you're placing a stent, and then you have to have biopsy forceps of multiple sizes. So that's the thing which you need, and you have to have both combination of flexible and rigid bronchoscope in your armamentarium when you are starting central airways obstruction treatment. I think now we move on to our next question. When do you consider doing airway stenting in a case of malignant central airway obstruction, and how do you select the stent? This question is for our panelist, Dr. Abhishek Prajapati. Dr. Abhishek.
Okay. Thank you, sir. So, first of all, stenting is a main measure for palliative therapy in central obstruction treatment. So it is used as a main measure of palliative therapy. It also used as an adjuvant or a neoadjuvant to the palliative therapy. Now, what are the main indications, or can stem level 1 indication whenever there is extrinsic compression because of the airway obstruction and there is an reduced diameter and difficulty in ventilation. So that is the most important indication. When there is an obstruction of more than 50%, even after debulking, cover that area with the stent, with some extra margins, then it is an indication of having stenting. Then we should have a clinical profile of the patient. We should judge that there must be a clinical improvement. There must be a good FEV1. There must be a good PA. And then
your voice is breaking.
Good quality of life. The patient's life expectancy should be at least more than 4 months. Then these are the level 1 recommendation. And then a relative indication. And after that, we have to judge before routing a stent, whether we have. Okay. So prerequisite for successful procedure is we have to have if the tumor is in a proximal location, like it is in trachea, mainstem bronchus, or bronchus intermedius, it will be having a better clinical improvement by putting a stent. If it is a localized disease, then there must be a functional bronchi and lung panel after putting a stenting. And if we judge by clinical history, if patient has developed acute onset of dyspnea, then it is indicative that patient having a sudden obstruction of a proximal airway. That is level 1 recommendation. Then in this case, if we put a stent, we will have a better improvement. Then progressive dyspnea, then there plus or minus. But if patient having no any dyspnea or having a dyspnea on exertion only, means there is a pulmonary.
I think we are not able to listen to you properly, Dr. Abhishek. Dr. Abhishek, we are not able to listen to you properly. I think we take up the question. Next, I think we move on to the next question. We are not able to listen to him properly. So sorry, Dr. Abhishek. We move on to the next question, which is, which are the cases? This is the question for our surgeon in our panel. Can we know from you which are the cases of malignant central airways obstruction where there is a definitive role of surgery, and what are the usual success rate of surgery in malignant central airways obstruction, and what are the complications for the same?
Thank you, sir. Most importantly, for the surgical resection, you have to have two aspects. One is the R0 resection. Other one is there is no involvement of mediastinal lymph nodes. So if these two fulfill, then you have a better prognosis. And nowadays, you do not have to remove complete lung like previously, or you do not have to remove a lung. Nowadays, you can just perform a sleeve lobectomy, sleeve pneumonectomies for carinal reconstruction, surgical techniques. So the airway can be better maintained. And coming to the outcome, it depends outcome. Usually low-grade malignant tumors are better out, up to 90 to 95%, especially in adenoid cystic carcinoma or carcinoids. But the tumors which are lung cancer infiltrating the trachea or the bronchus, they have slight lower as per even through the literature, less than like 40 to 50% or 30%. So it varies from place to place, center to center. And complications, most important complications, what we come across in the airway surgery is that anastomotic dehiscence, which is the most lethal complication that we face. Other complications which it depends on the surgical technique, how you perform the surgery and how you manage the sutures. And the next important complication that come across via the anastomotic strictures or stenosis, anastomatics and bronchopleural fistulas. And in this case, the management has to be on a very conservative type in some cases, or sometimes we might have to re-explore and operate and treat these cases. So this is from my point of view, sir.
Okay, thank you, Dr. Klein. Dr. Klein, how I think we often find it difficult to have good surgeons for doing central airways surgeries. That's a very difficult situation in India. Only very few centers have a good thoracic surgeon who can operate central airway cases. What is your say on that? That's a really problem for all of us.
Yeah, that is right. The central airway tumors, you require a good training, as well as you find very less number of cases overall when you compared to the other cases in the lung pathology. And in Indian scenario, most of our cases are inflammatory pathology. Coming to the malignancy. And malignancy, they prefer a particular center, which is very less in our country. So it requires a good training, and training from the master is the must for experience. So it depends from person, and even anesthesia team has to be equally competitive in managing these cases. It's not about one particular surgeon or one particular team, because you require a complete team, the management, post-operative management, and referring the patient at the right time by the pulmonologist. That also matters a lot. So
that's true.
Overall, it is most important.
Thank you. That's really wonderful. Now I think we move on to our next case, which will be on malignant pleural effusion by Dr. Raghukanth. Dr. Raghu, please share the case with us.
Sir, Gopal Krishna need to...
Yeah, sure. Yeah.
Sir, is it visible? Sushil sir, is it visible?
Yeah, visible. Yeah, please.
Yeah, right.
Full screen. Make it full screen, please. No, I think. Yeah, make it full screen. Yeah, no, it's good.
Right. Thank you, sir. This is case of recurrent malignant pleural effusion, majority of cases when the patient is involving pleura is advanced disease, and majority of cases were recurrent. So this case, I'm going to brief about a case which a 65-year-old male obese with history of diabetes and a past history of hernia repair 40 years ago. Initially presented elsewhere with the breathlessness of grade 2 to 3 for 10 days and worsening over grade 4 over last 3 days. So background, these obese and sudden breathlessness and no other clues. So outside they have done a CT pulmonary angiogram, CTPA, which we reported as negative for pulmonary embolism, but reported as a carcinoma of lung with mediastinal invasion and corpulence. And from there, the case was referred to us. After going through history, we reviewed the scans, and initial pleural fluid aspiration was diagnostic pleural fluid aspiration was done, which revealed hemorrhagic exudative low ADA, but cytology negative and infective workup was negative. So then we done a PET scan which showing a large upper lobe mass abutting the chest wall with a minimal effusion. So patient underwent as the patient is a chest wall. Okay, yeah, right. So as the patient, the large mass and it's abutting the chest wall, so the best way is to approach is the CT guided IR team. We involved IR team with then CT guided lung biopsy was done, and the report was turned out adenocarcinoma. Then PET scan was done, staging and the adenocarcinoma. Then we referred to oncologists. They started the chemo along with the immunotherapy. And the follow-up, the patient was reviewed in the OPD after a couple of weeks. Just a check X-ray was done, which shows the resolution of right upper lobe mass, but the effusion was remains stationary, like blunting. But after few months, he presented with severe breathlessness, and he was a continuous active smoker in spite of diagnosing malignancy. He was continuous smoking. He was laden with massive effusion, which required intubation. So we had done a pigtail to drain the fluid and slowly wean off and extubated and slow back to NIV. Slowly we weaned off the ventilator support, and it was doing good. From there onwards, the patient realized the severity, and then they stopped the smoking. And follow-up a couple of weeks in the OPD is doing good with off oxygen with the minimal support medication from pulmonology side, and continued the chemo. And again he presented with after a couple of weeks he presented with a recurrent effusion, again the moderate to massive effusion, and the size of the lesion was increased. Then we discussed with the patient the options available, and we considered the thoracoscopy as the pleural fluid cytology was negative, repeat pleural cytology negative. Then we want to confirm the diagnosis, and at the same time we want to give a therapeutic option. So we have done the thoracoscopy. Initially drained over 1.2 to 1.5 liter of straw color fluid. Then visualize the whole area. We can clearly see there's a clear-cut growth over the visceral and the parietal pleura. Then later, after drainage of complete this thing, then we are done talc pleurodesis. So you can see this snowstorm appear in this slurring. Talc was done through the thoracoscopic. So later on, follow-up in the OPD, off oxygen and no breathlessness and stop smoking, and he is continuing immunotherapy and others nebulized medication, and he is doing good. So the pleural effusion is a stationary. It's not too increased or decreased. It's almost like achieve a good pleurodesis. Thank you.
Thank you, Dr. Raghukanth. That was really wonderful.
Yes.
Now we move on to our panel discussion on this case. My
Yes.
first question is to Dr. Raghukanth himself.
Yes.
Now, which are the factors which guide you the choice between repeated therapeutic thoracosynthesis and definitive pleural intervention in a patient with malignant effusion? So how you decide whether in a particular patient you'll do repeated thoracosynthesis versus going for a definite pleural intervention?
So obviously the case is malignant pleural effusion and the pleura is involved always stage 4, and the prognosis is usually limited advanced stage. So we the first aim of is to palliation, like breathlessness should be controlled with minimal invasive procedures. So if the patient is having reaccumulation is weeks or weeks, days or week, and a slow growing tumor or something, then is initial visit, then always try to go for therapeutic aspiration. If you want a definitive treatment option, then we can consider either IPC or pigtail or ICD with pleurodesis or talc, thoracoscopic guided, or a pleurectomy with VATS. So all depends upon whether the patient is having an aggressive tumor, short lifespan, and the patient preference, because some patient they don't want to come repeated hospitalization, repeated hospital checkup. In that case, we can prefer only IPC and home management. We can train them and we can consider that. Or if the patient having a good chemo response, then the rapid accumulation is not there, then we can consider only just therapeutic aspiration either 1 or 2 times. If the 1 or 2 times fail, then we can consider the definitive treatment option depending upon the patient preference, cost, that is the most important, and the expertise, because nowadays the thoracoscopic role was increased, but if the even if we consider IPC, if it's a patient is trapped lung, so all this play a role when you're deciding the modality. But once you consider indwelling IPC catheter, but the cost is almost equivalent to the thoracoscopy. So we need to discuss with patients what is the factors, cost, and preferability, and other comorbidities, whether the patient is fit for the anesthesia and all that. We need to decide what modality. Then we can decide the plan, sir.
Thank you. I think we need to look at multiple factors before we go ahead and do any procedure. But yes, initial presentation, we may tap once or twice. And then if it is a recurrent pleural malignant diffusion and you already have a diagnosis, then you may have to go ahead and do a therapeutic procedure like talc pleurodesis. Thank you. I think we move on to our next question. This is to Dr. Karl Mehta. Dr. Karl, in a known case of lung cancer with pleural effusion, what are the situations when you consider doing medical thoracoscopy? Again, an important question for the beginners.
Thank you, sir. So, the important is what are the diagnostic indications? So, even though you have a known patient with lung cancer, you may have diagnosed it, and you have a pleural effusion, you want to know whether it's a transurate or exudate, depending on the patient's clinical scenario. So, infective or non-infective. Then you want to use a thoracoscopy to find out whether you have a recurrent malignant effusion versus a paramalignant effusion, and the paramalignant effusion is pleural fluid associated without cancer cells. So that's another important crucial decision. So that's where you want to know whether you want to drain the fluid or whether there's a new there's a different cancer that's taking place. It'll guide your management, and this is the reason why you're wanting to know why the patient is on having a existing malignant effusion, if at all. And then sometimes it's used even for staging of lung cancers. You have a lung cancer, and you have no other lymph nodes or Mets. So then you do a thoracoscopy to stage to look for, like Dr. Raghukanth has beautifully shown in the pleuroscopy, you look for lesions, take biopsies. So that's the diagnostic yield. And then when it comes to therapeutic indications, you want to basically relieve the patient of the fluid accumulation to help re-expansion of the lung. You can you can use a thoracoscopy to help you adhesiolysis, removing releasing the adhesions and clearing up the pleural space to help lung expansion. It can be used to strip the thickened pleura, which may happen if there's a ring formation. It can also be used in helping tunneling and putting in a tunneled pleural catheter in place as well. And then also chemical fluorodesis is the other real indication. So these are the kind of things you need to keep in mind.
Thank you, Dr. Karl. I think for the beginners, please understand that if you have a patient with malignant pleural, with known case of malignancy with a pleural effusion, and if your pleural tapping is not giving you a definitive cause, if you are not able to find the cause, if it is exudative pleural effusion but without a definitive diagnosis of the cause, then a thoracoscopy can help you to to examine the pleura, drain the fluid, and do proper pleural biopsies from suspected areas so that you can confirm the diagnosis, and then if needed you can go ahead with a therapeutic intervention in the form of fluoridesis. So I think thoracoscopy has a very important role in management of patients with malignant pleural effusion. I think we move on to our next question. This question is to Dr. M.S. Gopalakrishna. Dr. Gopala, how do you diagnose and manage a patient with recurrent malignant pleural effusion with trapped lung? Again, an important clinical entity. So can we know from you how you manage these cases?
Yeah.
Diagnose and manage patients of malignant pleural effusion with trapped lung.
Yeah, a trapped lung with a pleural effusion is always a challenging, especially for diagnosis and management. First of all, we need to differentiate whether it is the effusion is due to malignancy or it is because of paramalignant effusion. So we have to do a cytological workup. If it is proven that then it's due to malignant effusion. If the cells are negative, then probably that is due to paramalignant. So what could be the reason for a trapped lung in malignancy is mainly due to preceded pleurosynthesis or maybe a chest tube, which can induce the inflammation in the pleural cavity. So that can cause adhesions and follow loculations, can cause a trapped lung, or maybe endoluminal obstruction can cause atelectasis and may produce a trapped lung.
Sometimes even the malignant cells, they can infiltrate the pleura and then the lung remain trapped. It doesn't expand. That's one thing, infiltration by the malignancy itself.
Yes, sir. And especially with the mesothelioma, there won't be much effusion, but because of the large tumor chunks can cause a trapping of the lung. So we need to establish the diagnosis before going for the proper management. So you need to have a good imaging, especially X-ray and ultrasound usually helpful to look for the diaphragmatic movements and lung expansion after the drainage. And CT is very, very useful. It helps to pick up the pleural thickening nodules and fibrosis around the lung. And what could be the reason for trapping? So CT can give a good clue. Sometimes pleural manometry can be helpful, especially when we are doing a pleural thoracentesis. And thoracoscopy is the diagnostic modality of diagnosing a malignant trapped pleural effusion, because we can able to inspect the entire pleura, and at the same time you can do a adhesion lysis and you can take the biopsy. All these things can be done with our thoracoscope. Then coming to the management part, the best treatment modality is if it is a single large loculated pleural effusion, the patient is symptomatic, simply we can put a chest drain and drain the fluid. But in case of multiple loculations, which is not allowing to place the drain, then IPC is the option, because IPC is very easy. The learning curve is very simple. So it's a daycare procedure. We can insert the IPC in endoscopy room. So patient can be discharged in the same day. And the best advantage is the patient can be managed the catheter by himself at home. And the infection risk of the IPC is very, very less. So the best treatment for any malignant effusion with a trapped lung is the IPC. And another important point is fluoridesis can't be done because the trapped lung, the infection risk and the lung may not expand will cause failure of the fluoridesis.
So I think that's an important message to the audience, that if there is a trapped lung, don't attempt to do a fluoridesis unless the lung has completely expanded. The fluoridesis will not work. So you have to make sure that the lung has expanded enough, so and it is abutting the both the pleural surfaces abutting to each other, and then only you consider for fluoridesis. Otherwise, if you do fluoridesis in a trapped lung, it will not work. It will cause more problems to the patient. So the important message is, if there is a trapped lung with a malignant effusion, IPC is the choice of modality which need to be used in such cases. I think we move on to our next question. This is to Dr. Abhishek Prajapati. Dr. Abhishek, when do you consider doing TAL fluoridesis in a patient with lung cancer and pleural effusion? And what is the success rate and what are the potential complications? Dr. Abhishek.
Okay, thank you, sir. Sir, am I audible now?
Yeah, please. Thank you.
Okay. So when to do a talc prodosis? So first of all, patient should be symptomatic because of the malignant pleural effusion. There must be a dyspnea, and which should resolve after the pleurodesis. The lung should be completely expandable after complete drainage, as you said in the previous question. There must not be any trapped lung. Expected survival should be more than 4 to 6 weeks, so that patient will get adequate benefit. And patient preference, because patient might be wanting a one-time hospital procedure instead of a prolonged home drainage like in IPC. And there must not be any contraindication, like it should be avoided in trapped lung. There should not be any pleural infection. We should not try it if when pleural fluid pH is too low, and or there is an uncontrolled bleeding diathesis. So how should it be performed? It should be done by a talc slurry via chest tube, 4 gram in 50 ml NS, or talc powderage via medical fluoroscopy or thoracoscopy. When the thoracoscopy we are doing, we can do biopsy or radiolysis in additional, and ensure good lung pleura apposition before installation. And as far as the success rate is concerned, so success rate is 70 to 90% in achieving pleural symphysis. And best outcomes are there when drainage is less than 150 to 200 ml per day before installation and lung fully is expanded. As far as the complications are concerned, the complications are common, minor one are the common, like pain and fever, which are mostly self-limiting and managed with the analgesics or antibiotics. 20% cases, failure or recurrence can be there. In such cases, we have to go for the indwelling pleural catheters. Infection or empyema are though rare, but can be possible, and which can be managed with the antibiotics plus or minus drainage. And hypoxemia or ARDS like reaction are very rare, but it can happen because of the and it can be minimized by the large particle talk and avoiding overdosing. And sometimes arrhythmia or vasovagal reaction like during procedure is possible. So have a better monitoring during the procedure and manage as per the protocol. Like we should have better to have some anesthetics bedside to manage all these complications or side effects.
Thank you. That was really wonderful. Nowadays, we hardly see ARDS because I think this was happening because of the particle size, which was there were much smaller particle size, which was the American talc, which was available, which used to get absorbed, and that was causing ARDS. With the current talc, which we are using, the French talc, usually we don't see the ARDS. So that's an important message that ARDS usually doesn't happen, and it is the talc fluorosis has minimal complication and should be used in appropriate cases. I think now we move on to our next question to Dr. Klein Dantes. Dr. Klein, in a patient with advanced lung cancer with multiloculated empyema, again a very not so uncommon situation, is there any role of wax?
Yes, there is definitely a role of wax in this case, and it has to be referred at the right time. Trapped lung is also an indication because the surgical involvement usually involves you have to mobilize the lung completely, especially when you operate any case of multiloculated effusion or a trapped lung or a decortication. Only placing a catheter might not benefit these patients because we have come across many of these cases and we have performed these cases with very gratifying results too. So mobilization involves you mobilize on the right side up to the like hilum to hilum and superiorly from superior vena cava and medially laterally at least. So these anatomical structures are most important. And once you mobilize the lung, the expansion of the lung is good and it responds very well. So this is
The only thing is because these patients have very less survival, and so probably for good quality of life, when a patient is otherwise fit enough, we may consider doing VATS because it's already a known malignant pleural effusion, now complicated by a multiloculated empyema. So would you suggest in that or any specific way to pick up which patient you should do and which patient you should not?
So if he is able to tolerate single lung ventilation, then it is fine. We can go ahead with surgery. If he is not able to tolerate single lung ventilation, usually I prefer to go with, even if the patient is on chest tube or a pigtail, we just give urokinase, streptokinase or kinase infusion so that it improves his quality of life. So we are performing many of the cases. Every time surgery is not an indication, every patient. It is Selectively, we have to be very careful in selecting the patients.
Yes, correct, agreed. If the patient's performance status is poor and patient may not be able to tolerate surgery, then we may consider other modalities like streptokinase or urokinase, and sometimes even a simple medical thoracoscopy and try to remove the adhesion septations with that. That may also help in certain situations, and it can be done under local and sedation. So you may attempt to do it in order to help the patient in a very specific situation, not in every patient. Thank you. My last question is to Dr. Subhajit Sen. In a patient of malignant pleural effusion, what are the indications of IPC, and what are the common complications of IPC, and how do you manage them? Again, important question for the beginners.
Yes, sir. So, in malignant pleural effusion, usually we consider IPC in patients who are having non-expanding lungs. So, in these patients, usually we put IPCs, and considering the survival, the duration of survival expected in this patient is decent, around 3 to 6 months. In these patients, we consider this patient for IPC. Also, patients who have failed pleurodesis, in that patients also we can consider IPC, and the patients who have loculated pleural effusions or multiloculated pleural effusion, through that also, those patients also we can consider IPC. These are the standard ATS malignant pleural effusion guidelines, which has given the indications of IPC. Also, in the guidelines, they are saying that in patients who have we have performed therapeutic thoracocentesis and we have seen the lung is expanding, in those patients also we can consider IPCs, and there are some studies like Time 2 where they have shown that the IPCs actually have better success rate compared to ICDs and chemical pleurodesis. And we can also remember that through ICD we can also perform pleurodesis. So in that patients, it varies case to case, but that case in patients also we can consider IPC. The complications regarding IPCs are less. I think after insertion there is patient complaints of some pain, which are manageable with analgesics. There are some complications like cellulitis, which occurs at the insertion site. If you have a proper insertion technique and we can maintain the insertion site properly, so this is not a problem. The pleural space infection rate, if it is done properly in a sterile environment, is actually very less. Personally, I haven't faced any patient who came with pleural space infection after IPC. There are some other complications like migration of tumor cells in mesothelioma, which is I have only read in literature. I have not seen a case where a mesothelioma is seeded through the tunnel of IPC. And sometimes the IPC tube get blocked, but it can be easily managed through flushing. And training of the patient how to manage the tube and how to drain the fluid properly is important. If the patient can manage that properly at home, I don't think IPC causes that much of problem to the patients.
Thank you. That's really a very elaborate and excellent explanation about when to use the IPC and what are the possible complications about it. I think now we move on to our next case by Dr. Karl Mehta. Dr. Mehta, please share your case on hemoptysis, which is again an important complication of lung cancer.
Thank you, sir. I hope everyone can see my slide. I'll go to full screen just now. Where did it go? Yeah. Yes.
You are visible.
Thank you.
Yeah.
Yeah, thank you. So this is a patient, 67-year-old lady, kept complaining of recurrent hemoptysis. She was a case of papillary carcinoma thyroid in 1998 with a recurrence in 2007 along with lung metastases. It's at this time where she came with presented with hemoptysis, which was I'll come to those specifics later. Just additional medical comorbidities include grade 3 ductal CA breast, on radiotherapy, diabetes, hypertension, gastroesophageal reflux, osteoarthritis. She was not on any anticoagulants or antiplatelet medication. Her hemoptysis was about 100 ml a day. So she was quite stable. So she was taken up for a therapeutic video bronchoscopy. The bleed was noted coming out of the lateral basal segment on the left side. A tissile fibrin sealant was injected, as well as Cy6 bronchial valve, intrabronchial valve was deployed. And then again, the tissile sealant was reinstilled at this level. So she goes home, but then 2 months later, she has hemoptysis again around the same amount. So you're wondering whether the valve did not hold, or the valve went down, or it got dislodged. So did that fail? That was the question. So again, we go in. Since she remains stable with airway breathing and circulation, we did a check. We went in with a video bronchoscopy again. We found an active bleed, this time in the posterior basal segment of the left lung. The similar procedure was done with the fibrin-based sealant tissile. Then again, we did a size 7 spiration was deployed, and the sealant again to cover it. So these are the images that you see. Basically, what is the tissile sealant? It's just it's a combination of synthetic aproteinin factor 8 and fibrinogen with thrombin combination. So it's quite natural, basically. So these are the advantage of this is that it creates a web, like a bandage, and this web is then it's a web. It gives an effective seal. It's quite adhesive, and over time it can get resorbed. So it allows for the natural process of the body to fibrose and heal. It creates a scaffolding, and it's a natural fibrin clot, synthetic version of natural fibrin clot. I just thought this was something interesting for everyone to know. Thanks.
Thank you. Thank you, Dr. Karl. Now, just for the audience to understand, yes, the fibrin glue is a very good method to stop bleeding, especially in mild to moderate or recurrent hemoptysis. This is not usually used for severe hemoptysis, and unfortunately, the valves, spiration valves, are not available in India, so we are not able to use them. But yes, they have been used in the UK and Europe and US for managing these patients. In India, we usually use either fibrin glue, or there are other techniques which we'll be discussing in our panel discussion. Now, my first question is to Dr. Karl Mehta. Dr. Karl, what's your clinical approach to a case of hemoptysis? We are especially discussing about a patient of hemoptysis, especially in a case malignancy situation, and in a case of malignancy. Yeah. And how do you investigate them? So, what is your way of handling these cases? A case of hemoptysis coming to your OPD.
So, patient, yeah, when you're suspecting a patient with hemoptysis, obviously, based on the history, you want to know whether the patient is stable or unstable. If a patient is stable, you can immediately send them for a CT scan with contrast to try and identify the source, whether there is so in this case, we're looking at malignancy. Where are the growth? Is it a central airway, or is it a peripheral growth? So that's what you want to know, whether it's invasive or not, whether it's a mediastinal mass. So you want to know that. And if the patient is stable, then you admit the patient, work him or her up, and then take them forward for the bronchoscopy visualization. And then you can do then you can identify where the site and source of bleeding is. And then you can take the appropriate steps, whether you want to use a blocker, whether you want to use tamponade, whether it's infective, then you just need to pull out and use therapeutic management. And there's also the basic management will be just using cold saline, seeing if that stops the mild bleeding, or you can use adrenaline or tranexamic acid. So there are various ways. But if it's an unstable patient with massive hemoptysis, more than 100 ml, frank bleeding because the bronchial arteries are involved, then you need to do the first important things are maintain airway, check the breathing, and then secure the circulation. Only one, and stabilize your patient. Also, giving position of the patient. So identifying which lobe of the lung you're getting the bleeder from, and then making the patient lie on the dependent side so that you're able to secure it. You can even use, if you have a competent anesthesiologist on hand and available, you can use either bronchial blockers if you want to just obstruct, or you can use single or double lumen tubes that can also temporarily arrest the situation while you stabilize the patient. If you need to give transfusion fluids, you can correct everything. Once they're stable, then you can definitely proceed to the similar management of CT and then bronchoscopy. And then and then, as I said, when you have identified the source of bleeding, you're able to either use a cold saline or topical epinephrine or balloon blockers. And if the patient hasn't stabilized, or there's a growth which is actively bleeding, then you've got to consider also under high risk and OT, you want to take them up for, if you're a competent center, for advanced bronchoscopic treatments like balloon tamponade, laser, APC, or stenting. So these are some of the things that you have to keep in mind.
Thank you. So if depending upon where the lesion is located, if it is a central airways obstruction due to a mass or a tumor, then you have to go for debulking with your laser, cautery, and other modalities and the rigid scopes, or even sometimes it's flexible. And if it is a peripheral lesion from bleeding coming from the periphery and there is no obvious mass seen, then maybe you have to use balloon tamponade, or you have to balloon blocker or other modalities. And even if it is mild to moderate, then maybe you may consider putting a glue there to stop the bleeding. I think that's the very good comprehensive way of explaining how you approach these patients. Now we move on to our next question to Dr. Subhajit Sen. Dr. Subhajit, how can you differentiate hemoptysis from hematemesis? Again, that's an important thing. A lot of times we are not sure what is it, and the patient doesn't give a proper history. Then how you deal with it?
Yes, sir. This is sometimes a tricky situation that we face, that sometimes the patient cannot give a proper history. But if the patient is able to give history, our investigation will start, our line of thought will start from history only. So whether the patient having a history of cough, any respiratory disease, the blood is coming with a sputum, this will indicate more toward hemoptysis. Whereas the patient is having nausea, vomiting, retching, a patient with chronic liver disease, or a patient with gastric or peptic ulcer, it will more indicate it is a hematemesis. So if we are not getting a history properly, then we ask for some specific question like the color of the sputum or color of the expectorant rather. So if it is bright red with frothy sputum and it is mixed with sputum also, so it is usually indicated of hemoptysis. For hematemesis, it is usually coffee ground color, dark color, but sometimes if the patient passes old clots, it may also looks like blackish colored expectorant, so that may be confusing sometimes. In that case, we can go for additional testing, like we can, if it is available, we can test the pH of the expectorant. So usually for hemoptysis, it is usually neutral pH or alkaline pH. For hematemesis, it is usually acidic pH. So these are the common things that we can do apart from clinical history or other imaging or further investigation, which will indicate that the patient is having hemoptysis rather than hematemesis.
Thank you. Sometimes we may even need an endoscopy before we go ahead and do bronchoscopy.
Yes, sometimes it is so perplexing.
Sometimes it may be difficult, and you may have to ask a gastroenterologist to do an endoscopy in occasional situation, not everyone.
Yes.
And I have seen situations when they have done an endoscopy, they didn't found anything there, and then they referred us for bronchoscopy to look for the cause of.
Yes.
Okay, I think now we want to move on to our next question. This is again to our surgeon, Dr. Klein, Dantes. Dr. Klein, what are the clinical situations where surgery can be life-saving in patients with severe hemoptysis? Again, important question for our audience.
Surgery plays definitely a selective role, especially in crisis, but it is most critical and life-saving procedure. So one should know exact site of bleeding before going for the surgery, whether it is from the lobe, whether it is from the vessels, particular. Especially if it is a lobe, you can resect a lobe, or you can perform a wedge resection or a segmentectomy. And we have come across the cases where patients have presented with anemia. That it is due to the intercostal bleeding, and we could not identify the site of bleeding. Even pulmonologists found quite difficult. So when we explored, we could find lot of clots. However, patient survived even with a hemoglobin of 2. We could bring back the patient. So exact site of bleeding is must in this kind of patients, especially for the surgical.
Thank you. Usually we need surgery in very occasional situation in severe hemoptysis when every other modality has failed. Maybe in last 25 years, I have seen maybe 2 or 3 times when we have to actually ask the surgeon to intervene because everything else failed. So yes, but certain situations, yes, it is useful. And I think we need you guys whenever we are in trouble. So I think we move on to our next question to Dr. Abhishek Prajapati. Dr. Abhishek, when would
Yes,
you consider doing bronchial artery embolization in a patient of hemoptysis and lung malignancy? Which are the
sir.
situations when you consider it?
So the clear indications are the clinically significant or life-threatening hemoptysis means any bleed which is causing hypoxemia, airway compromise, or hemodynamic instability, which are called a clinically significant life-threatening hemoptysis. In these scenarios, we have to be ready with the calling of interventional radiologists early. Or recurrent or persistent bleeding despite initial medical or bronchoscopic control, like ice saline, we have used topical epinephrine, tranexamic acid, APC, laser or cryotherapy, and we have not succeeded. This is the time we have to go for the bronchial artery embolization. Then in CT pulmonary angiography, there is it demonstrates hypertrophic bronchial or non-bronchial systemic feeders or contrast blurs or pseudoaneurysm. There is a predominantly extrinsic or vascular tumor bleeding where debulking alone won't be durable. And as a bridge to definitive tumor control, like palliative RT or systemic therapy, or to facilitate scheduled endobronchial therapy. So these are the indications where we have to go for the bronchial artery embolization. How we should proceed in a massive hemoptysis? We should have to take care of airway and breathing first as a protocol. We can use tranexamic acid 1 gram IV over 8 hours. And in arterial, in CT pulmonary angiography, we should localize the site, map bronchial or plus non-bronchial systemic supply, and exclude pulmonary arterial source. So whenever there is pulmonary artery involvement, we should not go for the bronchial artery embolism. That is the dictum. And when we should not use, whenever there is pulmonary arterial source, we have to go for the pulmonary artery coil or plug embolization in that case, but not a bronchial artery embolization. Whenever there is uncontrolled sepsis or empyema, as literature says that, we have to mention here. And whenever there is in end of life care or the patient is moribund, and in such scenario, we should not go for the bronchial artery embolization. In this, we use typically PVA particles, which are size of 300 to 700 micrometers, and we have to check that we should identify the anterior spinal artery origin, and we should embolize only distal to it to avoid spinal ischemia. Otherwise, we may have a spinal paralysis to the patient, and this should be taken care very precisely.
Yeah.
And we should not use the proximal coil that may block the future access unless specifically indicated. And with this, we can have a 70 to 90% control of the bleeding. And in rebleeding, incidents are 10 to 30%. And as far as the complications are concerned, these are only chest pain or dyspepsia or fever, and in non-target embolization, in some cases, spinal cord ischemia.
Thank you. I think that's important information to all of us, and especially to the students who are here in this webinar. Now we move on to the last and the final question of today's webinar. What's the role of bronchoscopy in managing patients with hemoptysis? And which are the different bronchoscopic tools and techniques which can help us in managing these cases? This question is to Dr. Gopala Krishna. Dr. Gopala.
Thank you, sir. It's a most debatable question. So whenever there is a hemoptysis, there are always that question arises like, is it imaging first or the bronchoscopy first, or is who has to manage this case, either an intervention pulmonologist or a intervention radiologist? But being a pulmonologist, our choice of management is a bronchoscopy, because bronchoscopy is having its own advantages than imaging. So it allows to visualize the tumor directly, So by direct visualization, we can assess the tumor severity, we can assess the tumor vascularity and extent of the tumor and erosions, and especially for localization in case of bilateral lung lesions. And especially we can use either flexible or rigid, depends upon the situation. Flexible bronchoscopy, especially for management of minor and moderate amount of hemoptysis. So it allows to diagnose as well as to manage the bleed by using different modalities like thermal ablation techniques and lung isolation techniques by placing the double lumen endotracheal tubes, or for placing a bronchial blocker. You need to have a flexible bronchoscope. And rigid bronchoscope is having its own advantage because of that wide working channel allows to quickly clear the airway contents, especially useful for in case of severe hemoptysis.
Thank you. I think we conclude today's webinar now. Any comments by any of our panelists on this topic? Anything more you want to share with us? Everyone is welcome.
One sentence. 1 minute.
Yeah.
Sir, not always we need to do a bronchoscopy. It's a timing important, and the setup where you are doing a bronchoscopy, because sometimes it may be catastrophe, but doing a bronchoscopy, we need a other IR team and all this high equipment should be there.
I think preparedness is important, and you don't need to do a bronch in every patient to start with.
Yes.
Mild hemoptysis, you don't even need to do any bronch for that sake. And only if it is moderate to severe, and when you are going in with your scope, better be prepared for therapeutic intervention if there is a need. So preparedness, again, a very important thing. Thank you for highlighting this important point. And I think now we conclude. Any other comments from any of our panelists?
Thank you, sir, for moderating. Thank you from all of us.
Thank you.
Thank
I
you, sir.
think we conclude today's webinar. I hope that we have given some important points and messages to all our audience who have been listening so well with us. And I especially thank the CCI for giving us an opportunity. My special thanks to Dr. N.H. Krishna, Dr. Vijay, my dear friend. Then we have Dr. Ashish Dubey, Dr. Anil Maske, Dr. Atri, and the whole team of CCI who has really made this webinar so well, and they are so useful for the students to learn, and they have become a benchmark for all of us. Thank you, CCI, for helping us to do this webinar and allowing us to share our experience with each other. Thank you. I think we end this webinar now.
Thank you so much.
Thank you.
Thank you.
Thank you.